everyone, welcome back to my channel, and if you are new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to increase your knowledge and learn from the best PTs out there, start right now by subscribing to this channel and clicking on the bell so you don't miss anything, and give us a thumbs up and share this video with your friends. Today, our guest is Jack Miller, and he is a physical therapist with over 40 years of experience. He is also a Mulligan instructor, and he's going to talk about Advanced Practice Physiotherapy. I hope you enjoyed the show. Hi Jack, welcome to PT Pro Talk. How are you today?
I am very well, Mariana. Thank you very much for the opportunity to be here today and share with you and your listeners. It's a great privilege. Thank you.
Such an honor to have you here. Thank you so much for taking the time. So let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Fair enough. Well, it's kind of a little bit of a checkered past. I'm from Canada. I did my physiotherapy undergraduate training at the University of Toronto. And I always tell this story because it's kind of a fun one. I thought that the training that I got was pretty good. However, I didn't really have the skill that I was looking for to treat patients the way I thought that I was going to. When I was a young guy, I thought about different careers, and so I spent some time watching a doctor doing some work, and I realized they're just putting their fingers in yucky places. I don't want to do that work. Then I thought, okay, maybe I'll be a dentist and watch what a dentist does. And again, they're just putting their fingers in yucky places. And no, I don't want to do that. And then I watched an optometrist for a while. And my goodness, what a boring job. Number one, number two, number one, number two. Didn't want to do that. And then I had an opportunity to spend some time with a physiotherapist. And I watched what this physiotherapist by the name of Gord Andrew was doing. And I thought, wow, that looks really that looks like a lot of fun. I want to do that. And so I went to physio school. And so every day I'd show up at physio school, and I thought, okay, well, they're going to teach me what I saw Mr. Andrew doing, and they never did, because what I didn't realize at the time is that Mr. Andrew was a physiotherapist. He trained in the United Kingdom, but he's also a graduate of the British School of Osteopathy. And what I was watching him do was high-velocity thrust manipulation. I thought, well, that's what physios do. And so they didn't teach me that. So after finishing physio school in 1980, that long ago, I started taking the Canadian physiotherapy program's manual therapy program at the time. And I sat down one day and I did the math, and I realized it's going to take me like 10 years to get where I want to be. So I decided to speed up the process. And so I decided to take Jeff Maitland's manual therapy program in Adelaide, Australia. And at that time, Maitland brought in about 20 students, most of which were Australians. And so there weren't many places for the rest of the world. So I thought, maybe I'll just improve my chances of getting into the program, and I'll just simply show up and pretend that I'm an Australian. Yeah.
How did that work?
It didn't, because on the way so I bought a one-way ticket to Australia, and I'm flying to Australia, and on the way to Australia, I saw that the plane stopped on its way to Australia at this country called New Zealand. I knew nothing about it at all. But I thought, hey, I got some time. Before the school program starts, maybe I'll take a little bit of a holiday. I'll take about 6 weeks, I figured. I'll do some backpacking, sit at the beach, drink some beer, just take it easy. 6 weeks, I figured, yeah. 6 years later, I left, along with with my New Zealand wife, our New Zealand baby, and Diploma of Manipulative Therapy from the Auckland University of Technology and the New Zealand Manipulative Physiotherapy Association. So I was the first non-New Zealander to do their Diploma of Manipulative Therapy. And I got there in 1980. So I got to, when I went through the program, I got to take my McKenzie training in New Zealand from McKenzie.
Wow.
And I got to take my Mulligan training in New Zealand from Mulligan. And I used to be able to go and hang out at the clinics and watch them work. And it was kind of interesting because they were always asking, like, why are you here? Why are you here in New Zealand? you're Canadian, why are you here? And I kept saying, you guys are doing stuff that is so weird, it's so different. And they didn't realize, I don't think, they were, well, no, we're just doing the usual. So I happened to be there just at this formative time when the New Zealanders, I think, really were making these quantum leaps forward in musculoskeletal physiotherapy. So I got to be there when Mulligan discovered mobilizations with movement. And later on, Brian recontacted me after I returned back to Canada in 1986. Years later, Brian and I reconnected and invited me to be a Mulligan teacher. And so I teach Brian's courses here in Canada, United States, and the Caribbean as well. So my background is, again, I'm a physio, trained in Canada, but then I did my manipulative therapy program in New Zealand, came back to Canada, I did a master's degree at the Western University here in the city of London, Ontario, where I live, and then also a DPT through the University of St. Augustine. And that's where kind of, my interest in advanced practice, which is what we're going to be talking about, really came, because my capstone project was Advanced Practice Physiotherapy, Spine Surgery Triage, because at that time, what I was doing, and still do, is screen patients for orthopedic surgeons. Because here in Canada, we have social health care, which is great. There's only one lineup, and it doesn't matter if you're Bill Gates or the person living under the underpass. There's one lineup for healthcare, and which is wonderful. But the problem is that then creates waiting lists. And so what I do is I help to screen patients to make sure that the people that the surgeons see are appropriate. And we'll talk a little bit about advanced practice as it goes along, but that's kind of what I now spend most of my time now doing. And so I still have a clinical practice, but it's more so consultative is probably the best way of really putting it, more than treating directly, helping guide the treatment process. Not here to tell physios how to treat their own personal patients, but rather be collegial and, hey, have you thought about trying this particular type of approach? You've been doing ultrasound for this person's back pain for the past 8 weeks. They don't seem to be moving an awful lot further forward towards function. How do we start getting them moving and a bit more active? So that's kind of what my role is.
Nice. What a background. And what a spot to be. New Zealand, everything happened there. So I think you went to the right place on the right time.
You're absolutely right. One of Brian Mulligan's mottos comes from Pasteur. When Pasteur discovered pasteurization, it was by chance. And the Paris Academy criticized him, saying that was just chance. It was just luck. And Pasteur responded, in the field of scientific discovery, chance only favors the prepared mind. So again, I was lucky in many ways, but I think I was also prepared. So luck is where opportunity meets preparation. So right place, right time, hopefully the right person as well.
For sure. Absolutely. So our topic today is going to be the advanced practice physio. So for our listeners that don't know, what does it mean?
That's first of all, the definition of what advanced practice physio is very regional and very dependent. In the United Kingdom, it means a certain thing. In Australia, in Canada, again, they all have different meanings. But I think probably the best way to think of it, conceive of it, is just as there are nurses and nurse practitioners, there are physios, and let's call them physio practitioners if you want to, advanced practice. Now, that doesn't mean they're better, but they've gone on to do other more specialized training. And what their job is different than the bedside nurse, a nurse practitioner's job. They're not trying to displace the physician. They're not trying to take their job. They're trying to ensure that the patient gets the best possible care at the right time. And advanced practice physio really got rolling in the United Kingdom back in the 1990s when the government at the time realized that, look, just again, because they have a mixed social healthcare, private healthcare system, the national health system, and they were just throwing money at the national healthcare system, specifically to physicians, and thinking, well, we just give more money to physicians, that's going to fix healthcare. And of course, it didn't. And so what they did is they said, okay, now look, all you other health professionals, dentists, podiatrists, physiotherapists, whoever, we've got a problem here, and if you think you can help us, come and talk to us. And to their credit, the Chartered Society of Physiotherapy in the United Kingdom put forward a really strong case, a really strong submission, saying, look, we are experts in a large range of healthcare problems that involve mobility and function. Why don't you let us do our jobs properly? We've got trained people who can help you. And the government at the time initiated a process. And they have now gone through, and it goes by different names. The United Kingdom, it used to be called extended scope, but I think we're now kind of all using the same terminology of advanced practice. And so there's now a highly formalized training process, university-based, United Kingdom, and physiotherapists there can train up to a level where they order all diagnostic imaging, where they prescribe a certain scope of medications, where they can refer directly to all medical specialists, where they can do injections, joint aspirations. And so they're able to be this first contact, particularly in the area of musculoskeletal medicine, but they're now expanding that out to other areas of specialization within physiotherapy, say women's health, etc. And so, but we'll focus primarily on the MSK side of it. So in the United Kingdom, they really have taken the bull by the horns and have a highly formalized training process where physiotherapists can work their way through a post-professional training system towards being this advanced practice physio with more and more rights and operate, again, at that level of the physio practitioner, if you want to call it that. And it's fully funded by their national health system. I've got several friends in the United Kingdom who work in that and do a great job. And when they recognize that the person is outside of their scope, well, then of course, then they're not going to try to just continue treating the person. They work with the medical colleagues that they work with, and so that's what the things really got started in the United Kingdom. Then not too far behind it, Australia, New Zealand, particularly Australia, again with their mixed private-public system. In their public system, again, they realized, look, again, just throwing more money at medical care doesn't fix the problem. And so again, they have now I believe it's two university-based advanced practice programs that train physiotherapists to work at that level. Still have quite a few friends back in New Zealand. I was just speaking to a couple of them last week on a Zoom call like this. And their system is like Canada's, so I think they and us are very similar in the sense that there's not a formalized university-based post-professional training program towards advanced practice, but there are physiotherapists fulfilling that role. And the New Zealand and Canadian systems are very similar. I'll speak to the Canadian system because the New Zealand one pretty well mimics it in many ways. So here in Canada, as I said, we have a socially funded medical system, not a health system, a medical system. So if you want to go to any physician, if you want to go to any hospital in the country, it's fully funded through our government health system. There are, however, health services outside of that. Optometry, dentistry, podiatry, physiotherapy are not covered necessarily by the health plans that are administered by each province. So physiotherapy treatment is a separate issue. But within, again, advanced practice physio, what we found is that because we have social healthcare system, there is only one lineup to see that orthopedic surgeon for your hip replacement or your back problem. And it doesn't matter if you're Bill Gates or the person living under the bridge, there's one lineup, and no matter who you are, you get at the back of the lineup. Simple as that. And that's great. However, it also creates a situation that it creates waiting lists because there may be people in the lineup that don't belong there. And the research that I did for my capstone project on advanced practice showed that, at least in Canada at that time, 86% of people sitting in a spine surgeon's waiting room did not belong there. And so they're clogging up the system. And so this is what I did my research on and shared that with some people. And so an orthopedic surgeon who trained here in the City of London and is now in Toronto, Ontario, Dr. Raj Ramprasad, realized an orthopedic surgeon does spine. And I was able to do a presentation, and he was at it and thought that, that this sounds interesting. And so what was created approximately 8 years ago was a pilot project here in the province of Ontario of the Interprofessional Spine Education Assessment Clinics, ISAC. And what this was where allied health professionals, physiotherapists, chiropractors, could apply to work in this project and screen patients. So our jobs were to receive patients directly from the family doctor and undergo a really thorough examination, history, social history, health history with the patient, and then make the decisions about what sort of stream they should fall into. And obviously the vast majority of them didn't need to see an orthopedic surgeon. What they really need was education, activity, reassurance. Your back pain doesn't need, simple back pain does not need to have screws put into it. Here are some things that you can try. Why don't you come back in 3 or 4 weeks and let me know how that went? Oh, you're doing well? Great, continue on with the program. Or, hey, look, you've got back pain. You've tried some simple things on your own. They sound like they're the right things. Look, here's a list of some people that in your community that you might want to resource. We write a consultation letter to that practitioner and making, again, collegial suggestions about management strategies that may be appropriate. Or in that very small select group of people, we can start to ramp it up. So as an advanced practice physio, what we can do is facilitate further investigation. A study done way back in 2009 by Ash showed that if you take a large cohort of people with back pain and you MRI them all, and this half you read them the outcome of the MRI, and this half you say you've got your back is fine, don't worry. At the 1 year mark, which group is better off for mobility, function, and pain? Well, we know the answer. It's the people you said, yes, your back is normal, don't worry. So why are we taking all these MRIs? And so what we can do again is ramp that care up and order and facilitate the imaging if necessary. But again, you try not to, because again, it's spending taxpayers' dollars, but it's also psychologically and functionally harming the patient. Well, we're supposed to, above all, do no harm. We can also order, get to facilitate laboratory testing. So again, a 35-year-old male comes in, back pain, uveitis, urethritis, stiffness lasting more than an hour in the morning. I think that we should investigate your C-reactive protein, erythrocyte sedimentation rate, and maybe even run an HLA-B27 antigen screen. We can facilitate that through the primary care physician, make sure that they're getting those investigations. Last patient I saw before COVID-19 hit us all is a patient, this is a true story. I saw the patient at 9 o'clock in the morning and took the history. And they had their emergency decompression cauda equina surgery at 9 o'clock that night.
Oh, wow.
And so that's what we can do when needed, is facilitate that and make that happen immediately. Because again, when that patient goes to the hospital to emerge, send them right away to the emerge with a note, a handwritten note. Making it very clear what the suspicions were, and to make sure that the patient, a physician, put on the glove and did the rectal exam properly, and did so, and again facilitated the appropriate care. And then the patient came back after the surgery, obviously very thankful, and then we gave them some rehabilitation exercises to do, and they're now back at work and doing very well. So that's kind of where Canada is right now, is we do not have a formalized university-based post-professional training in advanced practice. But myself and my associate Rob Werstein, we have an organization called Key Clinical Skills. So what we've done is to help our peers, because Rob is also advanced practice physio here in London. And again, he did a master's degree and a DPT in the States. And again, so what we do is we have a online pharmacology, diagnostic imaging, differential diagnosis, laboratory testing, and triage clinical reasoning program where we help our peers towards that post-professional level of advanced practice. So again, here in Canada, it's not a title, it's a job description. So anybody can call themselves an advanced practice physio, but it's just simply what your job title is, because it doesn't have a separate designation, whereas in the United Kingdom, it has a separate designation, just as nurse practitioners have a separate designation from registered nurses. But our vision is, again, to work towards a university-based program. Rob, my teaching partner, and I to a smaller degree, but Rob really was intimately involved in creating Canada's first university-based manipulative therapy program here at Western University in London. So we do have models of a community program that then morphs into a university-based program, as most tend to do. So that's what we're working towards, and hopefully that will happen over the next couple of years.
Nice. So that's all very interesting. I never heard about that here in US, but so you as PTs, do you do a screening, but you do physical therapy properly saying, or you just referral and try to screen what's happening, and then other professionals are going to treat them? Is that right? Or
well, yes and no, in the sense, it's always you're wearing, different hats at different times. And so, most people who work as an advanced practice physio in Canada and the UK as well have a regular physiotherapy practice where they treat patients. But you got to be very careful of conflict of interest. So if I see somebody as an advanced practice physio, I can see them once or twice in that system, but I absolutely cannot undertake then a long-term treatment relationship. That'd be a conflict of interest. And so I refer out to another practitioner to take that role on. But again, most physios working in an APP position have a kind of a blended practice. Tuesdays and Thursdays they work as an APP, and the other days of the week they treat people walking in off the street with whatever problem they have. I think that there's different models. The other model that's out there, which is kind of really, I think, exciting. So right now, it tends to be more surgical and specialization screening, screening for rheumatologists, for patients who have got spondyloarthropathy, screening for potential surgical patients for our orthoneurosurgeons. So that tends to be what's going on. But we also have the rapid access is expanded now beyond spine. So we have the rapid access hip and knee programs. Again, looking at people who are potential surgical candidates for total hip, total knee, and that program is going to expand in 2021 onto shoulder, neck, and ankle. But also I think the really exciting thing is working with our medical colleagues in family health teams. So again, here in the province of Ontario, physicians can be still the sole practitioner, the lone wolf, so to speak, by themselves, but that's pretty lonely. And it's been shown that care by a sole practitioner is really not nearly as good as a team approach. And so most physicians now kind of gang together as groups, right? And they may all be in the same medical building, or they may be scattered in a region, but they cover for each other. And so what's now happening is that advanced practice physios are taking on jobs within these health teams, and basically you approach the physicians in the health team and say, look, I'll look after your MSK patients. So when the patient phones up, the receptionist, and says, hi, I'd like to talk to Dr. Smith. And the receptionist goes, can I ask what it's about? And the patient says, I think I'm pregnant. And the reception goes, tick, 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 sure, Dr. Smith will see you next Tuesday at 2 o'clock. Or, hi, I'd like to see Dr. Smith. Can I ask what it's about? My back is sore. Well, would you like to see our advanced practice physio? No, I want to see Dr. Smith. All right, well, that'll be 3 weeks next Thursday. Or you can see our advanced practice physio tomorrow. It's all covered by the healthcare system. And if the physio has any concerns, they'll get you to see Dr. Smith that very day. Now, what would you do? Wait for 3 weeks next Thursday, or see the advanced practice physio tomorrow? Because with all tremendous respect to our primary care physician colleagues, they have on average about maybe 15 hours of formalized training of assessment and treatment of the entire musculoskeletal system. That's their formalized training in medical school. Now, I'm not putting them down. They've got to deliver babies. They've got to deal with terminal cancer patients. They've got to deal with medical conditions that are outside of our scope. And so, you know, what our job is to help them to again, see those patients in that medical group. So you could have one physio for 10 doctors working full time. And you see the patients, and the patient comes in, and again, they're that young 35-year-old with the spondyloarthritis. You say, you know, this doesn't sound right. I'm going to get you to see Dr. Smith, and Dr. Smith's going to run a whole bunch of blood tests. In fact, actually, let me fill in the forms for him. He'll just sign them, and when you come back to see him next week, we'll have all the results done for you. Oh, it came back negative. Perfect. That's good. We got rid of that. We got rid of that problem. We don't need to worry about that anymore. It's now something that I, as a physiotherapist, can help you with. And again, it's fully covered. And why? Because what we really want to do, I think, is move from an illness system to a health system, to a wellness system. And how do we do that? Do you wait until a person is sick and then do something about it? Or could you have, you know, a dietitian? So again, in family health teams, we have dietitians, we have social workers, we have physiotherapists. And what their job is to keep that population being looked after by that health team healthy. And wouldn't that be great? You know, so again, if you worked in a family health team that had a lot of seniors, would it not be appropriate for the physio to be running and setting up a falls prevention program? Why not? And liaising with the local YMCA to make sure that they have a good program and directing the patients in that family health team towards that falls prevention. Or wait until a person falls, breaks their hip, and then have to deal with a fractured hip as well as their pulmonary embolism.
Yeah.
So again, advanced practice physio currently is, at least in Canada, primarily at the tertiary level, you know, that end point level. But what we're moving towards, and what the UK has done, is really move us more towards that primary care level, and that's where I think the real future is. But again, you need a good, sound foundation grounding in medical imaging, and not knowing more about how to read an X-ray, but knowing when not to order an X-ray, and to tell the patient, no, you don't need more imaging. You know, to be able to explain to the patient who insists that they need another CT scan of their low back, you may want to say, well, you do understand that 3 CT scans of your low back is the radiological exposure equivalent of a survivor of Hiroshima.
Oh, wow.
They tend not to want that 3rd CT scan after that one. You know, 1 series of low back X-rays is the radiological exposure equivalent of 120 chest X-rays. Now, you know, we're not trying to scare people, but we're trying to be judicious with our use of health resources, but also, I mean, exposing the people to unneeded radiation, but also all the fear and the medicalization. Jeremy Lewis, who's an advanced practice physio from the UK, a good friend, as well as Chad Cook, just wrote a really good article, just an editorial in Journal of Orthopaedic Sports Physical Therapy, and that is too much medicine, the elephant in the room, and well worth resourcing, because it really talks about this. We over medicalize our patients and actually do them harm by doing so. So again, I think what we're trying to get physios into is that role of that primary care practitioner, where they can work with their medical colleagues, know when to ramp patients up to further medical care, and then when not to. And think of this again, and obviously I'm going to date this podcast. We're right in the middle of COVID-19, and so wouldn't it be nice to be able to free our medical colleagues to do what they were trained to do, which is save people's lives? That's not my job. Remember, I'm the guy that didn't want to put his finger in yucky places. And so, but what it does is it frees them to do what they were trained to do. And lets us do what we're trained to do at the same time. And who benefits? Well, everybody. There is no loss there. We all benefit from that.
No, it makes total sense. It would be wonderful if that would happen in the whole world. So we would facilitate everyone's life.
Well, we all have different, systems in that. And here in Canada, we now have advanced practice physios on our East Coast provinces in Nova Scotia, in our French province, Quebec, Ontario, Saskatchewan, and Manitoba in our prairie provinces, as well as British Columbia on our West Coast. So we've got about 5 or 6 of our 10 provinces all have different programs in place. And we're running different models and, trying to find the best possible, 2 or 3, and then get those going on a consistent basis. Also when what it comes down to is when the payors, the people who pay for the service, realize that, look, you can spend less money and get better service. That's when the changes will come. Now for us, that happens because in each province, there's only one payor, the provincial health system. Whether or not this will ever happen in the United States, I couldn't say. Some obviously strong opinions both ways on that one. And as a Canadian, I'll be my usual polite self and just say, I don't know.
And just curiosity. So how long usually takes an average for the patient to receive this screening once he gets in the line?
Again, traditionally in the province of Ontario, before the Isaac program, I'll speak to the low back specifically because that's what I know most about. The wait list to see an orthopedic spine surgeon or a neurosurgeon 5 years ago was 2 years.
Oh, wow.
It is now to see an advanced practice physio, it is 2 weeks. And if we need to get the patient in to see the orthopedic surgeon, non-emergent, it is 2 weeks. Emergent, it's 2 hours.
What a difference.
So this is just it. So what we saw is that we reduced the waiting lists significantly and at the same time saw a significant reduction in cost, the utilization of imaging, happier patients, happier taxpayers, happier surgeons because they see who they get to see, happier physios. Again, that proverbial win-win. So we've shown some really good outcomes. There's been some good research going on currently. A research group from the University of Montreal, François Demille, has been publishing quite a bit of work recently. And it's been shown that, again, appropriate training program can take even novice physiotherapists. They ran a very small study at the University of Sherbrooke in Quebec where they took actually physio students and they gave them a very intense but brief training program in identification of spinal red flags. They demonstrated, again, high levels of interclass correlation coefficient comparable to spine surgeons as far as the ability to identify individuals who were appropriate or not appropriate for further investigation. So again, and this is why we're getting online training. You can do this all distance learning. You don't need to sit in a classroom to learn how to have appropriate use of resources. And I use this example a lot. So what's the utility of this thing? What's its utility? Well, it's actually to make it such that I don't squint when I go outside in the bright sun. That's its utility. What's its utilization? No. No. Yes. Oh, looking cool. I should do the rest of the podcast like that, right?
So people that are not watching us, just to know, he's using a sunglasses. He's showing some examples of sunglasses.
So if you were just listening, so I held up my sunglasses and say, what's the utility? And then utilization, I put them on the side of my neck. I put them on the top of my head. I then put them on my eyes. And so again, sorry, I forgot that we weren't all videoing this. And so, so it's not about utility is one thing. Utilization is the key to training in advanced practice. It's knowing how to use those tools properly. I mean, how many family physicians read your x-ray? None. They read the report. How many family physicians do the blood tests? None. They read the report, and they utilize the report appropriately to help manage your health conditions, right? So what we try to focus on in our training programs is not, yes, we do talk about utilization, how a chest x-ray is read, how a CT is taken, but most importantly, how to integrate that information into your clinical practice and use it to make wise decisions for the patient's overall management.
That's amazing. And how, so everybody that wants to work as advanced physio needs to pass through this training, right? You can just
no, again,
apply.
Again, in the United Kingdom, yes. If you want to work as an advanced practice physio, there are those post-professional programs. In Australia, again, they are moving more towards that. Canada and New Zealand, not so much. It tends to be a mixture. Some people is just simply on-the-job training, spending, I basically got most of my training by spending 5 years working with a spine surgeon. Just, basically every day in clinic, going into surgery, watching what he was doing, even assisting it sometimes. So I did put my fingers in those yucky places, just holding instruments, just so you can be up close and see what's actually going on. But so it's sort of like an ad hoc. Start off with an ad hoc, and then I formalized it through the DPT and learned more of the theoretical. So at this point in time, it tends to be a variety of different training options, not very formalized in Canada. So again, that's why I say it's not a formalized designation so much as it's a job title. And so, but we hope to see that change. We hope to see it move towards being a post-professional, university-based master's degree. And we're actually working with, in some discussions with a couple of Canadian universities, and hope to move towards that, say, over the next 2 to 5 years. And
how is the doctor's reaction to that? Do they like this integration? Do they feel like they are still in their jobs? Like, how does that go?
Again, it all depends on which doctor you're working with, right? It depends on whether or not when they got the white coat, they also got the white ego. I'm not trying to be insulting, but it obviously some interesting studies have shown that as far as interprofessional practice goes, the two groups, the two factors that will determine, not determine, what I'm getting at is what group of physicians are the most open to interdisciplinary practice? Young females. They are the most open to working in teams, to working with other health professionals. Now, that's not to say that old guys like me, who are physicians, are not, because again, they're very happy. Because why? Because again, if I'm in that family health team seeing the MSK patients, guess where the physician could be? On the golf course. And because I'm looking after their patients, seeing their patients for them. Again, what you're seeing, I think, is a real shift of that paradigm away from the lone wolf physician. I'm going to do it all on my own. I'm the doctor. Shut up, listen to me. Doctor knows best. And to the, that shared decision making with the patients, but also the shared decision making with the team. They're very happy to consult because they realize that. You got to prove to them, not by trying to show off, not try to be smarter than them, but by demonstrating that you know your stuff, that you've been well trained, that you're safe, because they're going to sign off the care of their patients to you and retain a lot of the legal responsibility, no different than they would, say, if a resident was looking after a patient, right? And so it takes trust, and that trust gets built over time. So so I think, if people are interested in this, your viewers and listeners, I think, the first thing is review yourself, reflect. Do I have the confidence? Do I have the training? Do I have the knowledge base? And if not, then start resourcing that and try to build some of that knowledge base. And then along with that, if you have those resources and that knowledge base, the confidence in yourself, being reflective practitioners, saying to a group of physicians, hey, I'd like to come into your practice and just, spend some time just observing, and just, and maybe even, see one or two people with you. And then maybe, you're getting called away from the phone. Well, I'll take the history for you. And the patient, when the physician comes back for the phone call, to say, well, she's a 72-year-old lady who fell down last week and is complaining of groin pain when she's walking, and all that pain goes away when she's sitting. That might be an insufficiency fracture of the femoral neck. Could we get perhaps some further investigations? What type of investigations? Well, it might show on a plain film X-ray with you're writing right now, but it's actually a lot better if you actually order either an MR or a bone scan. Would probably show higher levels of sensitivity and specificity. And so if you can do that, you're not trying to show off or displace, but you're helping the physician to do their job. And that's how you win respect. And then you build from that is what's happened. So what I did with an orthopedic surgeon is I just did that. I spent 2 years basically following them around like a puppy dog and showing that I could do that work for them, to the point where they basically had me see all of their pre-surgical patients. And probably a crude term, but it's one that surgeons tend to use, at least here, is the typical look to cut ratio. So how many patients do you have to see before you can do one surgery? For spine in Canada, again, it was 16%. When they would see patients who were selected by the Advanced Practice Physio, their look-to-cut ratio was 99%. Do you think that's a happy surgeon? Because do surgeons want to look, or do they want to cut? Choose one. We both know. So again, you're making their job easier, therefore they're happier. That's how you get there, is building that trust, but it takes time, a lot of work, and again, a lot of training to get to that level.
Yeah, that's very interesting, and I would love to see our profession going to that level. I know it's going to take a while. Some places probably are never going to happen, but that would be wonderful.
Well, it's one of those things that as advanced practice physio continues to grow in other areas, again, right north of you here in Canada, it's a place where you can look towards and say, hey, is that something that we might want to integrate? And of course, it's never going to happen fully. It's not going to happen overnight. But again, I'm sure that there are in certain and again, you have to excuse my ignorance about the American healthcare system, but in certain like health management groups or health management organizations, they might be interested in moving towards that sort of thing, where again, there's a group with a certain amount of funding, and they got to use that funding in a judicious manner. And again, advocating in the profession and having your professional associations advocate and towards that. One of the things that we've got in Canada is physios in certain provinces. So Alberta can order imaging, physios can order imaging. Quebec, physios can order imaging, and again, if they have the appropriate training. In Ontario, again, advanced practice physios can do that. Same thing in Nova Scotia. So again, advocating to work towards the right to be. No, I won't say that. That's not true. Let's not use the word right. Privilege. The privilege to be able to order appropriate investigations, because treat it as that. It's a privilege, not a right. Because if it's a right, you abuse it, but if it's a privilege, you honor it. So
maybe if in a couple of years, looking at the results and see how it works, in other places, it would stimulate people to start trying to implement.
We run currently an advanced practice certification program here through Key Clinical Skills. For Canadian physios, Americans, you're very welcome to come take it. It's all online, distance learning. And I'm sure a lot of it will be very familiar to individuals that already have a DPT in the sense of pharmacology, different diagnosis, etc. But again, it's geared towards working at that APP level, the training programs. So again, it's not about reading the X-ray. It's about knowing how to utilize the results of that investigation intelligently, and a big focus on triage, clinical reasoning, not about being a better physio treater, but being, again, more that decision maker about what, the pathway that the patient should be streamed down towards, whether we ramp up, ramp down, or possibly even just maintain at a certain level of care for any individual patient. So the triage and clinical reasoning is really important to appreciate.
Yeah, very nice. So I think we wrap up all the APPs. Yeah. Do you have something else?
No, again, first of all, thank you very much for the opportunity, Mariana. It's been a pleasure with you. Hopefully you and your listeners are interested in this topic and something that you'd push towards. If you're looking for more information, www.keyclinskills.ca is our website, and you're very welcome to come and visit that and see some of the offerings that we have as far as distance learning. And again, thank you very much for this opportunity. It's been a lot of fun. Bye.